Hi, I'm Dr. Gilat Englanoff, and I'm an emergency medicine physician. I'm here with Dr. Ezekiel Fink, who is a neurologist specializing in chronic pain management. I've suffered from chronic headaches for many years. We're here to talk about a new procedure using an invention of his named OcciGuide.
Thank you for your introduction, Dr. Englanoff.
Tell me a little bit about an occipital nerve block. It's not anything I ever got trained in.
So the occipital nerve block is a procedure where you administer lidocaine over the occipital nerve. The occipital nerves are responsible for pain and sensation on the occiput, which is in the back of the head, as well as sensation and pain over other parts of the scalp. By administering an occipital nerve block, you're blocking the pain cycle, and that is a really good treatment for headaches. And there are several reasons why it's a really good treatment. One is that it's rapid onset. So in an emergency room setting, you could administer this procedure and find out whether you're providing relief pretty quickly. The second is it's actually surprisingly long duration. So in multiple randomized control trials, it's been shown to last up to 2 weeks or even greater just with the administration of a local anesthetic. Another advantage is that when you administer it, you're only administering it locally and there isn't a systemic effect. And then finally, there are very few complications, and when they do occur, they're typically transient. So there's a lot of reasons why it could be a really good procedure for management of headaches.
So what is the OcciGuide?
So the OcciGuide, and I have one right here, is a user-friendly disposable device that was invented by me to increase access of the occipital nerve block to any clinician. And it's designed to account for the specific patient's anatomy and allow any clinician to perform the occipital nerve block on a patient where it is indicated.
So which patients are indicated for this procedure?
The occipital nerve block via randomized control trial has been shown to be an effective treatment for multiple headache types, including migraines, which affect tens of millions of Americans, cervicogenic headache, which is any type of headache where the neck is part of the trigger, cluster headaches, occipital neuralgia, the list goes on and on.
What are you typically injecting?
You're typically injecting a local anesthetic. I personally like lidocaine 1%. I'll inject 1 to 2 cc's per nerve. Other ingredients that have been shown to be effective in literature include bupivacaine and prilocaine, both of which are local anesthetics.
Okay. How often can patients get this procedure? Do I have to worry if they've just recently had it done?
You can safely do the procedure every 2 to 4 weeks. There have been multiple randomized control trials which show that it is effective up to 2 weeks just with a local anesthetic, and it can be repeated every 2 to 4 weeks safely. There are other trials which actually have demonstrated that doing it more frequently actually leads to a cumulative effect. So one trial did it every other week, one did it every week, and I think there was one trial that did it every 3 days or so. So a patient having the procedure previously is not a contraindication. In fact, it may confer additional benefit by repeating the procedure.
Big question. Complications, risks?
With any procedure, there are going to be complications. With this, fortunately, the complications are unusual, and when they do occur, they're typically mild. I break the complications down into 3 general categories. One are the types of complications that are associated with the needle itself, such as injection point soreness, or hematoma. The other is infectious complications, and finally, medication-associated toxicity or medication-associated side effects. Now, this particular procedure has been extensively studied in the medical literature, and in fact, there was a review article in the Journal of Emergency Medicine in 2015 which came out very strongly in favor of using this in the acute care setting, and one of the points it made was when you compare the risks and benefits of this particular procedure against the other potential options, it's just as good, if not better, than the other options available.
So if I wanted to use this in the emergency room, would you recommend me adding a steroid into the injection as well?
I really don't think it's necessary in the emergency room. Randomized control trials have shown that using local anesthetic alone, you get up to 2 weeks of relief, and it can be repeated if necessary. So adding that additional ingredient adds variables, it adds potential side effects of that medication. So in the acute care setting, I don't think that steroids are indicated.
What do you do with it after?
This is a single-use device, and there are several reasons for that. One, you're going to get blood products on this device when you perform the procedure. So for that reason alone, you discard it after one use. The other reason is there are multiple flexible components to this that help localize the pathway of the nerves specific to a patient. There is a very sensitive elastic band, there's a deformable metal arm here, and repeated use loses the accuracy. A final point is, if you were to try to sterilize this, the sterilization techniques available actually also interfere with the flexibility and the elasticity of the various components of this device. So for those reasons, it's a one-time use device.
So I love the idea of using this as opposed to writing another prescription for narcotic pain medicine. What do you think?
Absolutely. And to that point, one of the reasons behind this invention was to hopefully give doctors another option so they don't have to use opioids, either in the ER or at discharge. Also, if you use this and it provides patients relief, which you'll know relatively quickly, then maybe you don't have to put an IV line or try a bunch of other treatment options that typically are used at this point on patients with headache.
Tell us a little bit more about the device.
Okay, so let me show you a couple of features here that I think are important about the device. The first is that there's a headband that goes over the back of the head. This is designed to fit over the smallest adult female to the largest adult male cranium. This device operates by using superficial anatomical markers to line up the pathway of the greater and lesser occipital nerve. So there are two really important markers on this device. The first is the OcciGuide logo, and this rests directly over the occipital protuberance on the back of the head. The way to identify the occipital protuberance is to take your finger and run it up the midline of your occiput, and there's a bony elevation, and that is your occipital protuberance. This goes directly over that. Once that's in place, the second marker, which is the junction of this deformable metal arm and this elastic band right here, goes over the mastoid process, which is a cone-shaped bony projection behind the ear. So you move this down to the mastoid process, and that's on both sides, and this lines up the pathway of the greater and lesser occipital nerve specific to the anatomy of the patient that you're doing the procedure on. You can see once this is lined up, there's 4 injection ports. It's the greater and lesser occipital nerve on each side of the head. I typically use a 1 to a 1.5 inch needle that's 25 gauge. You can use a little bit larger or smaller gauge needle if you'd like. There's a couple of important points to doing this procedure. One is that when you enter the injection port, you want the needle slightly pointed upwards. And the reason for this is that actually enables you to contact the occiput at the earliest possible point. Now, when you put the needle through the injection port, you actually want to advance it down to the bone. And once you get to the bone, you want to slightly withdraw. And this is another critical point. Prior to injecting, you want to aspirate. If there's any return of bloody products, it could mean that you are intravascular. So you want to reposition the needle prior to injecting because you do not want to inject any of the local anesthetic intravascularly. And those are the major things to keep in mind when doing the procedure.
Once we've done the procedure, any special discharge instructions?
No. Once you feel the patient is stabilized, you can discharge them home.
So it sounds wonderful. How do we get something like this into our emergency room?
We would love to hear from anybody who has interest. Please contact us at www.occiguide.com. That's OcciGuide.com for more information, including training and how to get the product.
Wonderful. Now I actually do have a bit of a headache. Can we give it a try?
Absolutely. When performing this procedure, you want to make sure that the patient is properly positioned. I like to have the patient's head in a stable position to minimize patient movement. I feel a really easy way to do this is to have them in the seated position and to cross their hands on a surface in front of them and then place their forehead on their hands. If you see, this gives you good access to the occiput and the patient's head is stable. So I'm going to perform the OcciGuide procedure now. I have the OcciGuide. I'm placing it on the patient's head. I find the occipital protuberance and I place the logo over that. At this point, I want to clean the injection ports. And then I also want to clean the pathway of the nerves. I call this the upside down V. I go from the mastoid process to the occipital protuberance, and I clean the pathway. So occipital protuberance is here. This patient has hair, and this device works even with patients who do have hair. You just have to line this up with the anatomical markers. At this point, We bring the marker of the junction of the deformable metal arm and the elastic band down to one mastoid process. We bring the other marker down to the other mastoid process. If you notice, I'm moving the deformable metal arm in the middle. I'm not interacting with the elastic band. At this point, it's ready for injection. You want to advance the needle through the injection port, directing the needle slightly upwards, get down to the bone, withdraw a little bit, and then inject. And you want to follow suit at each one of these ports. So if you've noticed, this entire procedure occurs on the occiput, the back of the head, and at no point is any part of the procedure done on the cervical spine. If you find yourself in the cervical spine while performing this procedure, please stop and reassess how you're doing it, because again, this whole procedure should occur on the occiput. Once you're done, discard the needle. And that's the occipital nerve block using the OcciGuide. Are you doing okay?
Yes, great.
At this point, you delicately remove the headband, you discard it, and that's it. Thank you so much for watching this video and learning more about the OcciGuide. If you have any questions, please contact us at www.occiguide.com. Thank you.